because we were busy in morning rally, then after that Nukka Natak, and even Dean Dental Kgmu supposed to be here, but due to some because inspection is going on in our department, in all 6-7 department, so even our department also, so he couldn't attend. So so we'll start this program. I'm very happy to introduce Dr. Amit Singh. He's a MBBS and MD from Kgmu and DM in addiction psychiatry from AIIMS New Delhi. बड़ा अच्छा लगेगा इनको सुनने में क्योंकि his experience is was from AIIMS Delhi, and he worked in National AIDS Control Program also after DM. Now he is an assistant professor in King George Medical University, and he is having a good academic record. He is having right now 40 publication. So please listen and mute yourself, just so we can listen him properly. So over to Dr. Amit. आपका किस नाम से है? जो नाम से है पीछे ये है तो कोई बात नहीं, तो बीच में आए तो
So thank you, Dr. Vinay, for such a nice introduction. Myself, Dr. Amit Singh, and I'll be giving a talk on tobacco use disorder, the management strategies. Today is the World No Tobacco Day, and the theme for this year's World Tobacco Day is tobacco, threat to our environment. So tobacco is not just harmful to humans, it is also harmful to the environment. So with this pretext, let us come to the topic for today's presentation. I will be covering this presentation under following heads. So let's begin. So to begin, globally around 40% men and 10% women currently use tobacco. And cigarette smoking is the commonest method through which tobacco is used. Tobacco is also the most commonly used substance in India. In India, however, smokeless tobacco is the more commonly used form. It is responsible for 5.9% disability adjusted life years. Among the people who use various kind of substances, tobacco has been shown to be most addictive among several other commonly used substances. So, if if we take 100 people who use tobacco for the first time, 32 out of those 100 will develop dependence to tobacco. So here we can see that it is even more than some hard substances such as heroin, cocaine, alcohol and cannabis. And in tobacco, nicotine is the chief psychoactive substance. So various preparations of tobacco are available. It is available in smoked form such as bidi, cigarettes, hookahs, and it is also available in smokeless form such as snuff, gul, khani, gutka, pan masala, etc. The nicotine concentration in tobacco products is highly variable. In traditional cigarette, the traditional cigarette contains 6 to 13 milligram of nicotine. BDs have a lesser weight. However, they have 30 to 80% higher nicotine concentration per gram tobacco. So BD, though seems to be of lesser weight, is highly harmful. In smokeless tobacco products, the nicotine is 1 to 2 milligram per gram to more than 50 milligram per gram. So it gives us an idea that the nicotine concentration is highly variable in various tobacco forms. Coming to the epidemiology of tobacco use in India, around 28.6% of adults aged 15 and above use tobacco in any form. In men, 42.4% men use tobacco and around 14% women use tobacco. So every fifth adult uses smokeless tobacco form in India and every 10th adult smokes tobacco. Kgmu is the most commonly used product, followed by BD in India. The tobacco use disorder per se is present in around 20.9% of population. So this tobacco use disorder means that there is moderate to high dependence. People are finding it difficult to abstain from its use. In tobacco, nicotine is the chief psychoactive compound. It is actually a stimulant to the CNS, which leads to an increased release of dopamine. And this dopamine is responsible for the pleasurable effect which a person who uses tobacco experiences. The inhaled nicotine reaches brain in 10 to 20 seconds. So absorption is very fast through the lungs. And the effect lasts for around 2 hours. So every 2 to 4 hours, people might feel a need to take tobacco product or smoke cigarettes. The nicotine is metabolized to cotinine in liver. Now coming to the acute effects of tobacco use. With tobacco use, acutely what happens is a heightened alertness, relaxation and reduced fatigue. It also leads to appetite suppression. However, often it is associated with throat irritation, reduced sleep and increase in blood pressure and heart rate. Now talking about the long-term effects of tobacco. With long-term use, those who use tobacco products develop dependence to the nicotine, which is a disorder of regulation of nicotine use arising from repeated or continuous use of nicotine. And if a person tries to abstain from tobacco or stops taking nicotine products, they experience withdrawals. The withdrawals are characterized by irritability, frustration, anger, anxiety, reduced concentration, increased appetite, restlessness, depressed mood, and insomnia. Apart from this dependence, a long-term use is associated with various forms of medical complications. Almost all the body systems are affected with the chronic use of tobacco. It affects the CNS, leading to various kind of diseases, which is presented here in the table. It may lead to stroke. It involves oral cavity, cardiovascular system, respiratory system, GI system, reproductive system as well. It is associated with at least 12 forms of cancers, and this is a clear association. Besides this 12 form of cancer, it also contributes to various other malignancies. Now coming to the second-hand smoke. So apart from those people who smoke tobacco, the people in their surrounding also experience various forms of harms related to smoking. The second-hand smoke is a smoke from burning tobacco products and also smoke that has been exhaled or breathed out by the person smoking. So those who are in their near vicinity inhale smoke, and they also experience various kinds of bodily harms. So here there is a depiction of the harms which those people who are exposed to second-hand smoke experience. So in adults, it may lead to stroke, nasal irritation, lung cancer, coronary heart disease. Reproductive side effects are also there. It may lead to low birth weight in those who inhale tobacco fumes through second-hand smoke. Now coming to the third-hand tobacco smoke. So just not that the person who is smoking experiences harm, those in the near vicinity experience harms related to tobacco, and even the people who may not be there immediately but come in contact to the tobacco residues which are present in the environment later on also experience certain kind of harms. So the residual tobacco smoke that remains on indoor surfaces after the cigarette has been extinguished, those who are exposed to these residual tobacco smokes, they experience certain harms, especially young children living in tobacco using household, because these residuals are certain carcinogens, and small children, toddlers, they are quite prone to develop adverse effects related to exposure with these carcinogens. So tobacco contributes to most of the leading causes of death in the world. So there are various kinds of leading causes of death, including ischemic heart disease, cerebrovascular diseases, COPD, infections. So tobacco contributes to all of these leading causes of death. And all smokers, they die from, half of all the smokers, they die from tobacco-related illness rather than a natural death. Now, coming to the management of tobacco use. So, every physician or a doctor is supposed to address the issue of tobacco use in the patients or clients they are seeing on a regular basis. So, WHO and other international organizations, they have proposed certain algorithm that can be used, and these strategies can be used even in busy clinics. So what has been suggested is 5 A's, which can be used for treating tobacco use. So these 5 A's are ask, advise, assess, assist, and arrange. So I'll be discussing about these A's in upcoming slides. So to begin with, ask. For every patient at every clinic visit needs to be inquired about their tobacco use, and it should be documented on the prescription. So when a doctor is documenting the BP, pulse, weight, and other vitals, tobacco use should also be documented. The people who are seeking treatment should be strongly urged to use tobacco, to quit using tobacco. And this advice should be very clear. How can this clear advice be given? Is some statements can be used, such as यह महत्वपूर्ण है कि आप धूम्रपान या चबाने वाले तंबाकू का उपयोग छोड़ दें, और इसमें मैं आपकी मदद कर सकता हूं. Many times people would say that I use tobacco occasionally, so they can be said कभी-कभी या हल्का धूम्रपान भी खतरनाक है. This advice should also be strong, like मैं आपको यह बताना चाहता हूं कि तंबाकू छोड़ना इस समय सबसे महत्वपूर्ण काम है जो आप अपने अच्छे स्वास्थ्य के लिए कर सकते हैं. Also, the advice need to be personalized, like whatever harms that the person has experienced need to be highlighted, and based on those harms we give a personalized feedback. Like if a person has developed asthma, we can say continuing to smoke makes your asthma worse, and quitting may dramatically improve your health. So we can also at that point of time highlight the benefits of tobacco cessation. So we can say that even as soon as you stop taking tobacco, you will start experiencing various kinds of benefits. Within minutes, your BP and pulse will return to normal. Within a day, your lungs will start to clear out mucus and other smoking debris. Within 2 days, your ability to taste and smell will be greatly improved. Within 3 days, bronchial tubes will begin to relax, and you will experience increase in energy levels. In few months, your lung function will increase by up to 10%. Within a year, the risk of heart attack falls to about half that of a smoker. And if you continue to quit this tobacco, the risk of heart attack falls to the same level as someone who has never smoked. So we can highlight these benefits to the person to whom we are giving this feedback. Now, after we have given this feedback, we are required to assess the willingness of the patient to make a quit attempt. So we can ask, क्या आप अब तंबाकू छोड़ने की कोशिश करने के लिए तैयार हैं? If the patient is willing, we will provide assistance. If the patient is unwilling to quit tobacco at that point of time, we provide an intervention which to increase the future quit attempts. So, how this assessment will go on? Here, we elicit a detailed history of tobacco use pattern and assess the harms associated with it. We also assess the level of dependence, and we can use certain questionnaires, which I will be discussing in upcoming slides. So, a detailed history may include, depending on the time available to the physician, the age at initiation should be inquired, how it progressed, how the tobacco use has progressed over time, what its frequency, what is the quantity of tobacco form used, what is the tobacco product that is being used, various kind of physical, familial, social and financial problems or harms the person has experienced and which is related to the tobacco use should be inquired. Any past quit attempts need to be noticed down. So we should be asking the patients about the number of attempts which the patient has made earlier, the longest period of abstinence in the patient, the reason for trying to quit this time, the treatment taken if he has taken any treatment earlier, the reason for relapse, and any positive or negative consequence of the abstinence. We also ask about the reasons for seeking treatment this time if the person come to you to seek treatment by himself. Any perceived benefits or barriers are inquired, any comorbidities are noted down, and we also ask women about their pregnancy or breastfeeding status, because that might have a bearing on the medications which we'll provide to the patient. We also do a careful examination of oral cavity, respiratory system and cardiovascular system, and we can do a mental status examination if the person presents with anxiety, depression or some other form of psychological problems. We then assess the motivation to quit. So it all depends on how much time is available to you in a busy OPD. If the patient is admitted with you and you have enough time, you can go for a detailed evaluation. So in a busy OPD, the other way through which we can diagnose the severity of tobacco dependence is through Phagostrom nicotine dependence test. It is a 6-item questionnaire where we ask about how soon after you wake up do you smoke the first cigarette, then how difficult it is you to abstain from smoking in places where the smoking is banned. Then there are several other questions which is presented here. Out of these 6 questions, the 2 questions, how soon after you wake up do you smoke the first cigarette, and the other question, how many cigarettes do you smoke, are quite important ones, because even if we ask these 2 questions and rate the person's responses, it gives us an idea about their severity. So with the Phagostrom nicotine dependence test, out of these 6 items, based on their responses, we give a score. If the score is 0 to 3, we can say that there is no or low tobacco dependence. If the score is 4 to 6, we can say there is medium tobacco dependence. And if the score is 7 to 10, we can say high tobacco dependence. Now, based on the 2 questions which I have discussed here, that is the how soon after you wake up do you smoke the first cigarette and how many cigarettes per day do you smoke, we can elicit the heaviness of smoking index. So these 2 questions have a high predictive value, and when we ask these 2 questions, even based on these 2 questions, we can also get a score. If the score is 0 to 2, we can say there is low addiction. If it is 3 to 4, there is moderate addiction. And if it is 5 to 6, we can say high addiction. So these are very simple questions that can be asked to every person who is attending our OPDs. So similarly, there is a nicotine dependence test for smokeless tobacco also. So we have made assessment. We got to know that the person is having this tobacco use disorder. The severity we have assessed. Now, often lab tests can also be used. It is not needed on a regular basis in clinical management of patients, but depending on the patient and certain situations, the lab tests can be used. On a regular basis, especially in those who are experiencing certain kind of physical problems, chemograms, spirometry, ECG, X-ray can be done. Depending on the needs of the clients, tissue biopsy can be done if they have any lesions in their body. Then there are certain tests that can measure the nicotine exposure. One test that can be used is measuring the cotinine. As we have discussed earlier, cotinine is the major metabolite of nicotine, and we can measure this cotinine levels. So it provides an estimate of the tobacco exposure. Cotinine has a half-life of 18 to 20 hours compared to around 2 hours for nicotine. So it can be used more reliably to quantify the nicotine exposure over past 1 to 2 days. So it can be measured in blood, hair, saliva, and urine. Similarly, carbon monoxide levels can be assessed to get an idea about the person's recent tobacco use. Similarly, other tobacco alkaloids and nitrosamines can be assessed to get an idea about the patient's smoking habit or tobacco use. However, it is not very much needed to be done in a regular basis while managing patients with tobacco dependence. Now, for patients willing to quit, this assessment is now complete. We then move on to assisting the patient in treatment. The patient are aided in this quit attempt through counseling and medication. So what we do, what we can do is with the patient who is willing to quit, we set a quit date, which should ideally be within 2 weeks from the day the person consulted you. And then we ask the patient to tell his or her family and friends about quitting and request support. So this will make sort of an environment of making this quit attempt. Then we also discuss with them the challenges the person can encounter. So we anticipate challenges, including the withdrawal symptoms the person will experience after quitting tobacco. Then we also ask them to remove the tobacco products from their environment, because that will, these cues will increase the craving in the person to use tobacco again. And we then use approved medications in managing this tobacco use disorder. So I will be talking about these medications later on. The person who is seeking treatment can also be given some practical counseling. The goal would be total abstinence. Here, we also identify what has helped and what has not helped in previous quit attempts. And if something has helped him or her earlier while making quit attempt for abstaining tobacco, we build on the past successes. Those strategies can be used in this quit attempt also. We anticipate triggers or challenges, and we also ask the person to encourage other smokers in the household to quit. So apart from these counseling and other strategies, the patient may need information, or they may have some issues at some odd times, like when he is at home. In such situations, the patient can use the help of quitline networks. There is National Tobacco Quitline Services. The nodal center is Patel Chest Institute, New Delhi. The number is toll free, and it can always be, the person can give a call to this number and get assistance. Their problems can immediately get addressed through these quitline networks. Several problems which the person who abstained tobacco experience include low mood, some anxiety, restlessness. Complaint of weight gain is quite common in people who abstain from tobacco products, and often the person who made this quit attempt at times uses tobacco once or twice. So lapses are also common. So these need to be specifically addressed when the person comes in follow-up. So we now, the fourth A, the assist is over. We have assisted the person in making this quit attempt. Now it is also important to make the patient continue to be in treatment. Adherence is quite important. So we ensure that the person be in regular contact, and for that we set a follow-up date. Then we on the follow-ups we discussed about the problems the person has encountered, and we try to address them. Any problems which the person has experienced related to medications are also addressed. For abstinent patients, we congratulate them. If tobacco use has occurred, we review the whole circumstance and elicit the person's recommitment to total abstinence. And if a person is still feeling that there is some issue which cannot be addressed on just an outpatient basis, we can consider intensive treatment. So they can be linked to some intensive treatment facilities. So this was for motivated people. What to do for patients who are unwilling to quit? So we work on motivation enhancement. Motivational interviewing is a technique that is used to increase their motivation. So through general principles of motivational interviewing, we express empathy to the with the patient. We try to develop a discrepancy, like what are their future goals, and whether they will be able to achieve their future goals if they continue to use tobacco. So definitely there will be a discrepancy, and we try to make the person understand that if they continue to use tobacco, they will experience certain kinds of harms and they will not be able to achieve their goals. Then many times the person comes up with some sort of resistance, that I will not be able to do this effort, or some other form of resistance may be there. So we roll with them, we don't confront with them, and we support their self-efficacy. So how we approach? So again, there are 5 R's that can be used to enhance motivation. We discuss with the person what is the relevance of quitting tobacco and how it is personally relevant. That अगर आपने तंबाकू छोड़ दिया तो इससे आपको क्या क्या फायदे होंगे. So we have discussed several sort of benefits earlier, and we can make the patient realize the relevance of abstaining from tobacco. We also discuss with them the risks which the patient has experienced and which the patient might experience if he or she continues to use the tobacco in the same manner. So these are the first 2 R's, relevance and risks. Then the third R is rewards. So we discuss with the patient what will be the benefits of stopping your tobacco use. So the benefits may be improved health, the money would be saved, and their children would be healthier because the third hand smoke is going to harm their children. So these are the rewards. So these are the potential benefits we try to identify and make the patient realize. Then we also discuss the roadblocks. What are the barriers? Why you do not want to quit at this point of time? So the person may be fearful about the withdrawal symptoms, the fear of failure, that I might abstain it for a day or two, but then I will again start using tobacco. So we address these roadblocks, and then we keep on repeating this thing till there is an increase in the motivation of unmotivated patients. Then if again, if a person is not getting benefits from these brief interventions, we can use intense psychotherapy also, the cognitive behavioral therapies or relapse prevention therapies. So this was about the psychological perspective. Now, the pharmacotherapy. The pharmacotherapy is equally important while managing tobacco use disorder. So all the patients should be encouraged to use medications, and this is evidence-based statement. Except for those where these medications are contraindicated, they should be seeking help of these medications in their attempt to quit tobacco. So the first line medications that are approved include the nicotine replacement therapy, the Bupropion, which is an antidepressant otherwise, but has been found to be helpful in managing the craving and prevent relapses in tobacco use disorder. And there is varenicline. So these are the first line medications. The second line medications include Clonidine, nortriptyline, cytosine. Apart from Clonidine and nortriptyline, cytosine is not available in India, so I will not be discussing much about cytosine. Coming to the first line medications, the nicotine replacement therapy, various forms of nicotine replacement therapies are there in the market, which includes the gums, nicotine patches, lozenges, sprays, oral mucosal sprays. So various kinds of nicotine containing products are available, medications are available. The nicotine gums and nicotine patches have been found to increase the odds of abstinence by around 50% to 90%. Like the odds would be 1.5, 1.9. With Bupropion, it is around 2. The odds of abstinence is higher for varenicline. Or when we use a combination, the patch and Bupropion, the odds of abstaining would increase to 2.5. And if we use patch and nicotine patch and nicotine gum in combination, the odds would be further higher. That is around 3.6. So here we can see that the combination nicotine replacement therapy is quite effective, almost equal to varenicline, and this is more effective than Bupropion or single product NRT. So one should not limit themselves to using single product. They can use combinations also if the need arises. So nicotine in tobacco products is substituted by an approved nicotine delivery product, the nicotine replacement in nicotine replacement therapy. So nicotine which is given through these products relieves craving and also relieves uncomfortable withdrawal symptoms. It includes some short-acting preparations such as gum, lozenges, inhaler, and nasal spray. The long-acting preparations includes the nicotine patch. The patch can have a longer duration of action. The success rates are similar with these different nicotine replacement therapy products. So, coming to nicotine gum, how to prescribe nicotine gum? So, what is suggested is that the person should use one piece of this nicotine replacement product every 1 to 2 hours, or whenever there is an urge to use tobacco. So, what should be the dose? Like the nicotine gum is available in 2 strengths, the 2 mg and 4 mg. So if a person is smoking more than 20 cigarettes, we suggest them to start with 4 milligram nicotine gum. If the person is smoking 20 or less than 20 cigarettes per day, we suggest them using 2 milligram nicotine gums. The total nicotine which is supposed to be given to a person in a day is 60 milligram per day maximum. Here we use chew and park method for using nicotine gum. That the gum should be chewed, the juice should be kept in mouth, and the gum will then need to be parked in under the cheek. And once the effect of this the juice which is there in mouth goes off, that gum need to be chewed again. So this is chew and park method, and a person need to continue chewing and parking this nicotine gum till this bitter taste from this gum gets over, because that bitterness is due to nicotine. So if a person is getting nicotine after chewing this gum, it means that still there is some nicotine left in the gum. So what are the adverse effects a person can experience when using nicotine containing products? Usually mouth soreness, hiccups, dyspepsia, and jaw ache. So these are the common adverse effects which the person might report. So the person who is using nicotine gum, is suggested not to chew nicotine gum too fast or too soon after another, because that will lead to bitterness and a waste of that will lead to bitterness in mouth. Besides, because of this bitterness, the person might need to spit out the juice, so there will be a wastage. Then we also suggest not to chew more than one piece of gum at a time, and we suggest avoid eating or drinking for 15 minutes before and during chewing of nicotine gum for a better effect. So we have started nicotine gum in an individual. Then after starting, how to wean or taper this nicotine gum. So the person is asked to continue using the nicotine gums at same dose for around 8 to 12 weeks, and then the person can reduce one piece every 4 to 7 days. So every 1 week the person can keep on reducing gums. So if a person needs, let's say, 6 gums to manage their craving throughout day, the person after 8 or 12 weeks, that is after 2 to 3 months of use, can reduce 1 gum every week. So a common reason for failure of nicotine replacement therapy is either the person does not use appropriate dose of these gums, or they often start reducing these gums very soon. So to get a better benefit, they should be using this gum for relatively longer duration, that is 8 to 12 weeks, and even it can be further extended. So increasing the duration, the other strategy of reducing the gums is to increase the duration between the use of nicotine gum pieces. Now coming to nicotine patch. So for those individuals who smoke more than 20 cigarettes, we can start with 21 milligram patch once daily. We give it for 1 to 4 till 4 weeks. We give 21 mg patch for those who smoke more than 20 cigarettes per day. Then during the next month, we reduce it to 14 milligram patch once daily. And then in the third month, we can reduce it to 7 mg patch once daily. And after that, it can be stopped completely. For those who smoke less than 20 cigarettes per day, 14 milligram patches can be used for first month, and then 7 milligram patches can be used for second to third month. So for the adverse effects which a person can experience here can be local skin reactions, because when the patch is applied to the skin, it may lead to some redness, erythema, some local reactions can occur, and it may also lead to insomnia. So how to use nicotine patch? The patch need to be placed on a relatively hairless location on the body, typically between the neck and waist. We rotate the site to reduce the local skin irritation at one place. So if somebody has applied this patch on, let's say, right shoulder blade, then the next day we can ask them to use it on left shoulder blade. Then we can keep on rotating the sites on a regular basis. In several patients, even high-dose nicotine patch therapy may be required. That is more than 21 mg per day. So here we can use this more than 21 mg patches also. Like 121 mg patch can be given, and we can add further 7 mg or 14 mg patches. It can be used in those with high alcohol dependence, and this is usually safe and well tolerated. Among the individual pharmacological options available, varenicline is the medications with the highest efficacy. So it is varenicline is a nicotine acetylcholine receptor which reduces the severity of tobacco withdrawal symptoms. It reduces so like 3 months. It is started with the 0.5 milligram tablet per day orally. Then for this 0.5 milligram is given for first 3 days. Then fourth day onward till 7th day, the dosage is 0.5 milligram BD, and subsequent to it, from 8th day onward till 84th day, 1 milligram twice daily varenicline can be given. So it can be started 1 week before the person's quit date. The patient need to continue treatment for a total of 12 weeks, and regular follow-up is advised to check on progress and adverse events. The common adverse events associated with varenicline use is nausea, headache, insomnia, fatigue, abnormal dreams. The patients are kept on regular follow-ups, and any adverse effects are monitored. Initially, when varenicline was marketed, several cautions were advised. However, it was found to be quite safe, and except for this hypersensitivity contraindication, it has no major pharmacokinetic interactions with other psychotropic medications, and can be prescribed even in persons with cardiovascular events or those with some mental illnesses. So Eagle's study was done in 2016, which gives a clear idea that varenicline is quite safe. The third medication which we can prescribe and which is available in India is Bupropion. It can be used in smokers above the age of 18 years. To begin with, for first week, the person can be given about 150 milligram of Bupropion orally once daily. 7th day onward, we can increase it to 150 milligram twice daily, or for sustained release preparations, even 300 milligram once daily can be given. And subsequent to it, we continue till around 63 days. And if the person has stopped smoking, we can continue it. And if the person has not stopped smoking, we can discontinue it. The common adverse events associated with the Bupropion is dizziness, taste changes, GI disturbances, and insomnia. The contraindications associated with Bupropion is seizure disorder, and in alcohol dependence we observe a caution, because often person in withdrawal have a high propensity to develop seizure. It is also not advised in person with severe mental disorders, because there is a potential for switch to there is a risk for aggravation of those psychiatric episodes. Then, as I have discussed earlier, combination treatment is approved and is recommended. Nicotine patch can be combined with bupropion, it can be combined with gums, it can be combined with lozenges, and it has been found to be quite effective. So, what should be the duration of treatment? The long-term abstinence outcomes are better after 24 weeks of treatment than after 12 weeks. So here we can see that this study published in JAMA suggests that longer the duration of treatment, higher will be the benefits. Some second-line medications that can be used include nortriptyline, clonidine, and cytosine. However, these are not as effective as first-line medications, and these are not FDA labeled. So I am not going to discuss these medications in detail. However, nortriptyline can be used. The target dose is 75 to 100 milligram per day. Again, for 3 months it is given, and based on the person's response, it can be continued further. Similarly, clonidine is available in India, and it again can has shown benefits in system meta-analysis. However, the relative risk with which it decreases the use of, which it reduces the risk of relapse is relatively low compared to first-line agents. Cytosine is not available in India. There are various other medications that have been tried, but none has been found to be very effective. In pregnant females, nicotine replacement therapy is the only medication tested, and it has mixed evidence. It can be given. It is safer compared to if a woman continues to smoke during pregnancy. In adolescents, it is the counseling and psychotherapy that is recommended. With regard to medications, no medication is approved. So many times people often have a concern that we used to take some tobacco products, now we are using nicotine gums, even these are addictive. So this is a comparison of harms related to these products, which was done by David Nutt and other collaborators, which was published in 2014. Here we can see that the harms associated with patches, oral products, or nasal sprays, the nicotine containing products, is very less, 1 to 2% compared to smoking, the cigarettes on the far right end. And these are quite safe. So one should not be very scared to use these products. So to conclude, tobacco use is a public health issue. Majority of the individuals want to quit smoking, but the success rate remains low because often they do not seek help. They are not even provided medications many a time. The assistance provided can be extremely helpful in quitting it or cutting down its use, and combination of interventions should be provided. Thank you. So this was all from my side. If anybody has any questions or queries related to this presentation, please feel free to ask. I'll try to answer them.
Thank you, Dr. Amit. Thank you, Dr. Amit. Sorry, thank you, Dr. Amit, for this beautiful presentation. One question is there in the chat box that when it is actually nicotine itself that causes addiction, how can nicotine be a solution to nicotine addiction? This is from Dr. R. Pandya from Ahmedabad.
So, as I have shown in the last slide, am I audible? As I have shown in my last slide, that when we compare the harms which are associated with the use of smoking or other chewable tobacco products, when we compare it with nicotine replacement therapies, the harms are very less. And then we have a structure, we have a plan how to go about tapering down these medications. These are not to be continued for indefinitely. And if a person continues to use sorry for the interruption. So even if it need to be continued, the nicotine replacement therapy for long, it is still quite safe compared to if a person continues to use tobacco products.
Thank you, Dr. Amit. Then I would like to thank our respected Dean Sir, Dr. R.K. Singh Sir, Dr. Amit also for this wonderful presentation, IT Cell for providing this platform, and to all attendees who attended this seminar, this webinar, for giving your time. I request all attendees that share this information because it was very nice information, especially on the pharmacotherapy. No, in very few lectures, you will get this information. So share this knowledge with your friend circle and others. Do not speak that you should not use tobacco. Rather, you should also work for that. Advise your in your circle, whoever is there, not to use tobacco. And if anybody is already existing user, then ask them to quit tobacco. So with this, we end this webinar here. Thank you. Thanks for everything.
Thank you, everyone.